All right, well, everybody, welcome to the AOM Hands-On, Hands-Off podcast. Today, I get a wonderful opportunity to interview Jeremy Lewis, who is one of our keynotes at the upcoming AOM conference in Orlando, Florida. And we had a really nice conversation around, all sorts of things, including his background, what led him to shoulder pain, management and research, what also, he believes is the value of physiotherapy, physical therapy, including manual therapy and the approach that manual therapy can provide as a benefit for patients. And we sort of even dive off even into some more conversations around how physical therapy long-term, how the professions can look in different areas and different settings. And so a really nice conversation that we had today. And then a couple other big things. There was a key takeaway for, the keynote that he's going to be presenting. And then if you listen to the podcast, you'll actually find that Jeremy and I ended up with having a $10 bet. And I'm pretty sure I'm going to win the $10 bet, but you have to listen to the show to be able to figure out what that $10 bet was all about. Have a great one. Well, good afternoon. I think it is, Jeremy, in your time zone, and it's 8:30 in the morning my time here, so got a little bit of a time differential, so I'll probably have different hunger personalities and those kinds of things going on today with our show. But super excited to have you joining us at our AOMP conference this year and getting a chance to bring you over to the United States, bring you to sunny and hopefully not too humid and sticky Orlando, Florida. But wanted to get an opportunity to get the attendees that'll be showing up, or maybe those that are considering coming to conference, a chance to get to know you before you actually present our keynote, and also a pre-conference course to our attendees by doing this show. So thank you very much for joining us today.
It's my absolute pleasure, and it's a great honor for me.
Yeah, no, we're super excited. I know a lot of the people that I've talked to that are going to conference are really pumped to get to hear from you as well as the other keynote presenters. So, I know a lot of people probably, if they know your work, they obviously know your work is probably in the shoulder and that sort of thing. But can you give our listeners a little bit about your journey that kind of led you down your career path, if you will? I'm sure you've given this quite a bit, but and maybe you have a little bit of an elevator pitch, but just your journey that got you to this point.
Well, each time I get asked to do this, I give a completely different story because, just trying to keep one step ahead of everybody else, but I'll try and be consistent. So I was originally born in New Zealand, grew up in New Zealand, had a wonderful childhood, moved to Australia as a teenager, struggled to try and work out what I wanted to do as a career, eventually settled on physio. 10 years after I finished undergraduate training, I did the 1-year manipulative manual therapy training. Jeff Maitland was one of our teachers, so I had a great privilege of learning from him. And then a year after that, I did a 1-year sports physiotherapy course in Western Australia. And 24 years ago, moved to the United Kingdom. The plan was to move here for a year, but really enjoyed living here, and finished here another diploma in biomechanics. The scope of practice in the United Kingdom when I got here was rapidly changing, and soon after I got here, physical therapists were allowed to refer patients for any imaging, blood tests, etc. Then we were allowed to train to do injections, soft tissue and joint injections. I did an extra year or so to be able to use diagnostic ultrasound in clinical practice. I don't use diagnostic ultrasound so much for diagnosis, but I do use it for ultrasound-guided injections for frozen shoulders, which is clinical interest, research interest. And 2013, I believe it was, they changed the law again with an extra almost year's training. We were allowed to prescribe any medicine that there was an evidence base for that could support clinical practice. So it's been a really interesting evolution. I still firmly believe that the most important management that I can provide with patients with non-traumatic musculoskeletal shoulder problems is the traditional physiotherapy, physical therapy interventions that it certainly from a risk point of view, a harms point of view, it's much safer, probably more effective than injection therapy and pharmacology. So, I don't think we're in any way offering second best treatment with what we offer. So that's more or less what I do. I do 2.5 days a week clinically, and I work 2.5 days a week in research, doing my own research and supporting 10 PhD students around the world. And I also have the privilege of teaching a shoulder course, which I've just come back from teaching in Korea, Hong Kong, Kuala Lumpur, and 2 courses in India. So please excuse the black under my eyes. It's jet lag, and my voice is gone as well. So please excuse that.
No, that is totally okay. I understood. Maybe I don't understand because I don't quite have that same level of travel and teaching schedule for sure. But it's interesting that you
You're a lucky man then.
Fascinating background and fascinating history. It's interesting too. I think we could probably have a lot of side conversation, just in terms of scope of practices differences. And I'm sure that you've seen it in your travels throughout the world, what certain physios can do in certain countries. And that probably impacts a little bit of the way that you teach and manage. But I really appreciate that you mentioned that you firmly believe our traditional methods of physical therapy, are really what matters the most. But it'd be fascinating to just even hear, like, at some point, not necessarily today, but just how that scope of practice looks in the UK, because I know the United States certainly is leaning into a lot of those sort of advanced practice skill sets within our own industry, that it's obviously met with a lot of resistance, but that would be a fascinating topic. So I'm curious, and then I'm super excited also that you learn from Jeff Maitland. I know that will ring true to a lot of our attendees at AOMP conference. But more importantly, I was curious, how did you end up in the shoulder? I think everybody kind of has their ways. They may end up with low back as kind of their focus. Some people end up in the foot, the neck. You ended up in the shoulder. How did you get there?
It's sort of a bit like that movie. I don't know if you've seen it. The one with Gwyneth Paltrow. I've forgotten the name of it actually, but Sliding Doors. You might not have seen it. It's it's a movie where a person, half the movie is a person goes into the sliding door of an underground train in London, and the other half is she doesn't quite make the door. So what happens in her life when you go down these 2 different opportunities separated by a few milliseconds, really. I wanted actually to do specialize in an area. At the point in time when I was about to start my PhD, everybody was doing low back pain. Everybody was doing knee pain, hip pain. So I thought I'd go as far south as I could and look at try and become as expert as I could managing feet problems. And but I was really interested in the concept of posture, and I was also very interested in the concept of subacromial impingement syndrome. So I decided my great contribution to the world would be to demonstrate how posture causes subacromial impingement, and how when we improve posture, it reduces or alleviates the symptoms. And 3 years later, I'm probably the most confused person on the planet, thinking that, well, there's absolutely no evidence for postural theory that we follow so strongly, and there's no such condition as subacromial impingement syndrome. And I think that our subsequent research and research of many others has demonstrated that's the case, that the postural beliefs we have in our profession, we're probably just disabling people by telling them how poor their posture is, their muscle imbalance is, and asking them if they're related to Quasimodo. I think my PhD sort of blew that out of the water, and also it confused me no end that this condition that everybody was saying is the most common condition of the shoulder, impingement syndrome, probably didn't exist. And I guess as a consequence of that, I tried to think, well, okay, my first plan didn't work, but just stay with the shoulder and see what I can contribute with clinical knowledge and research knowledge. And that's where I got to. That's where I am.
That's great. So, so the things like upper cross syndrome probably drive you nuts at this point now.
I think what we're doing by perpetuating some of these clinical beliefs is just continuing to disable people who are seeking care. And, by telling them they've got impingement or telling them they've got subacromial pain syndrome, which is a meaningless, in my opinion, a meaningless diagnosis, because, then people ask, well, what's the subacromion? And then you talk about the structures in it. And then you talk about, well, what could be causing harm or damage to those structures. I think that's another meaningless term you give to patients. And you're sort of asking, well, who's benefiting from labeling a term like that? And to me, it makes as nonsensical as suprahumeral pain syndrome. So I think, labeling people with pathoanatomical diagnoses is very harmful, and telling people poor posture, and it makes it easy for us to explain symptoms. But the truth is we've got really no basis for a lot of what we say in clinical practice. And I love history, and I love medical history. And I've always tried to make an effort to go back to where some of these theories started from and how they snowballed or avalanched, or how they perpetuated. And very often it's just, I guess, a couple of people had a couple of vodkas and had a thought 150 years ago, or whatever the favorite tipple was, the drink was at that stage, and came up with an idea, and it just snowballed. And that's probably what happened with postural theory, sort of starting in Germany 150 years ago. It just sort of became existentially, that's not the wrong word, but it became very increasingly a sort of myth built upon myth built upon myth, and then it became fact. And I think that's the same for many conditions such as impingement syndrome as well. Because if you go back to the original paper in 1972, Charles Neer's original paper, and you read it today, you'd say, well, hang on a second, this is just reading like a blog. This isn't a scientific paper. This is an opinion piece. This is what I've been doing. This is what I'm believing. This is what I'm suggesting. But I guess in the 1970s, there was no such thing as a blog, and it became fact. But because of that blog, millions of people around the world, and probably many thousands of people around the world, including in your country and in the United Kingdom and many others today, are having a subacromial decompression, which has clearly shown not to outperform placebo surgery, and clearly shown with 10-year follow-ups not to outperform an exercise manual therapy approach. It's just adding expense to healthcare, reducing its sustainability. But it was started by basically a blog. And and I think a lot of the elective surgery that happens on the shoulders, whether it's rotator cuff repairs, whether it's type 2 slap lesions, biceps tenodesis, so much of it is these elective surgeries that we think we're fixing problems with are clearly not outperforming placebos. And we have to ask ourselves in whose best interest are these procedures being performed for? And, follow the money sometimes.
Yeah, and I really appreciate all those thoughts. Actually, the history behind it, I'm going to have to go and look at that 1970s paper by Neer, because obviously we resource that quite a bit. When I talk to PTs, I think one of the things that always frustrates, a physical therapist. So the example I give is, what do you do when a patient comes in and they say, I've got a herniated disc and it's causing my low back pain? Well, as a physical therapist, we're quick to jump in and say, well, it can't be your disc. There's so many people that are healthy that have healthy discs. There's people that are unhealthy that don't have healthy, so on and so forth. And so we jump onto that bandwagon. Yet, a few minutes later, we're quick to say something along the lines of, well, your posture is this. And it's like, so almost like the physio's version of a herniated disc, right? So like kind of talking out both sides of our mouths, which, I certainly understand it's hard to get those, it's hard to, untangle some of that mess that has been provided to us over the course of time.
Yeah, that's such an interesting reflection. You're 100% right. We think that some of the medical diagnoses that are given are just so ridiculous, but then we just label people with other ridiculous diagnoses or explanations for symptoms. And I think one of the worst things we can do is just to confuse people seeking care more by denigrating somebody else's diagnosis. I'd never say to a patient, it's ridiculous you've been given a diagnosis of impingement syndrome, or it's ridiculous that you've been told your symptoms are coming from your tear. I just think that's cruel to people seeking care. That we all need to speak with one voice, but the one voice we speak with needs to be an honest voice, and I'm not sure that's happening in musculoskeletal practice around the world. And I think there's a lot more we could be doing within our profession and between professions, reminding ourselves that the most important person in healthcare is not the physio or the doctor, it's the patient. And if we're not working to that ideal, that goal, it's questionable whether we're offering best healthcare.
Yeah, no kidding, definitely. All right, so I want to take a little bit of a deviation here since we're getting to meet you in Orlando. So without giving away too much, because we don't want you to give away too much, we want people to come to the conference. But can you share a few takeaways that our audience will gain from hearing your keynote?
Okay, with you, Derek, actually work backwards. I'm giving a 15-minute lecture, I think, in the morning of the night after a pub crawl. So I guess it's going to be me and the sound engineer in the lecture hall.
No, the physios come back. They bounce back really fast. You're going to be surprised. They're going to be a full audience.
Okay. Do you want to bet $10 on this?
Yes.
You might lose. Okay, so virtual handshake. All right. So anyway, so that lecture is going to be entitled "What Teaching in Iceland and Building a Shed Taught Me About Manual Therapy." And so that's the title of the short lecture, which I'm sure some people are going to find as somewhat as challenging as what I've been talking about with posture. I'm totally into touch therapy. I totally think as a profession, we should be doing manual therapy, touching therapies, but I think we maybe need to reframe it slightly, and I'm sure that's going to upset some people. I think there's ridiculous debates that are happening on social media about hands-on, hands-off are so irrelevant in terms of the important things we should be talking about delivering quality healthcare. We should absolutely be including touch therapy in our treatments, but maybe we should be thinking how we discuss them or explain them to patients and ourselves in different ways. So that's the second lecture. The keynote is going to be looking at what I would prefer to call my umbrella term for what people have called impingement syndrome, subacromial pain syndrome, partial full thickness tears of the rotator cuff, because in truth, we do not know for the majority of people if the symptoms are coming from those pathoanatomical diagnoses. And I think they should be consigned to, this is what we used to think, and we need to come up with a non-pathoanatomical explanation for patient symptoms. And I'm totally against the idea of calling it, you've got simple shoulder pain or non-specific shoulder pain. I think that's derogatory for patients. People who write about pain, people who are in pain, write about the need for, who tell us that the worst pain is an unexplained pain. And they also tell us that if a treatment doesn't make, if the explanation for their symptoms isn't clear, then no treatment will make sense and they won't engage with it. So we need to provide, in my opinion, a non-pathoanatomical diagnosis. So I've been promoting and pushing a term I came up with in 2016 to replace all those other terms, rotator cuff related shoulder pain. So the keynote's about rotator cuff related shoulder pain. And I'm going to try and make a case that we need to be thinking way beyond a bit of exercise and manual therapy. If we as a profession believe that a bit of exercise, bit of manual therapy can make a difference to this condition in the presence of someone who's smoking, not sleeping well, not exercising well, and with poor nutrition, we're fooling ourselves in a very large way. We're being very naive. And I'm going to try and make a case in the keynote that this could become a golden time for our profession, because so much of the elective surgery that's occurring for trying to fix the pain are not fixes. They're not fixing the pain at all. They're not outperforming placebos or non-surgical intervention, as I mentioned earlier. But what I think we should be doing, and our competition shouldn't be with another profession, it should be within our own profession. How do we do a better job? And what I truly believe we need to be doing in our profession is stopping this ridiculous debate about hands-on, hands-off, and trying to work out how we become experts in assessing lifestyle factors and supporting people through, in a non-judgmental way, supporting people through the process of behavioral change, which means we have got to put as much emphasis on assessing sleep quality, nutritional quality, general exercise participation, smoking behaviors, drinking behaviors, etc., as we do with anything else. And we need to think more holistically about the care we offer for all musculoskeletal conditions. We have to stop telling people we can fix them, because the evidence would suggest that we can't and the orthopedic surgeons can't. We need to just try and work out ways to restore people back to their valued activities. And it's naive of us to think that a bit of exercise, a bit of manual therapy can achieve that in the presence of other lifestyle factors. So I'm going to talk about this at a cellular level, how lifestyle factors can impact upon the health of tendon cells, tenocytes, so I'm not going to be only that will send people to sleep, but we need to think more in terms of a Venn diagram than we can thinking that, focusing in on what we tend to have focused in on for the last 50 or so years is probably naive. And maybe that's one of the reasons the outcomes that we're getting are less than desirable. So that's going to be my pitch in the keynote, but there'll be hopefully lots of good takeaway messages that people will value, and I hope it will also stimulate some robust conversation, discussion. Be interesting to hear how people react to that.
No, I'm super excited for that, and I, thank you a lot for putting something like that together. I think it resonates beyond obviously just the shoulder, but obviously it'll have the consequence with the shoulder. But I think that a lot of the progression and movement is toward that. I think you're gonna have an audience that'll be very engaged and interested in that as well. And I'm gonna win $10. You're gonna have a full house the morning after the pub crawl.
Okay.
It's pretty incredible.
Well, we will see. It depends who's most competitive. I might be prepared to pay $1,000 for people not to come just so that I don't lose face. We'll see. No, I won't.
All right. Well, I think that the topic title of itself is going to be interesting, especially, the people love those 15-minute talks too. Those are fantastic. So the next question I have for you is, and I think you're actually, you kind of have said this already, so I don't know if I want to ask a question, but I'll ask a question anyway, because it may just generate a different thought. You've already mentioned how management of shoulder pain has changed since you started, and you've been kind of responsible for looking at some of those different ways about it. But what do you see in the next 5-10 years? You kind of mentioned, I think I know where your answer is going to go a little bit with this, but in the management of shoulder pain itself, like how do you see? What, I guess, for lack of a better way of putting it, what keeps you excited about researching the shoulder going forward in the next 5-10 plus years, or whatever it might be?
I think I've only realistically got 10 years left. So the things that I would like to look at in the next 10 years are, I'm really interested in mechanisms, why exercise therapy and maybe behavioral change, lifestyle change could influence symptoms. I think we have to move away from structural explanations. We know that the surgery isn't repairing the tendon, and even if it does, that's not related to the reasons why people feel better. So then we've got a whole lot of pain people coming in saying it must be just something that's going on in the brain. But I think that's too far a leap forwards. I think, some of the evidence for some of the pain neuroeducation's pain beliefs is on less stable grounds than some of the evidence for manual therapy. What I'm really interested in is how exercise may change the biochemistry and may reduce some of the pro-inflammatory cytokines, the positively charged neuropeptides such as substance P, may change their concentration in pain-sensitive structures in the shoulder, and seeing how is that the mechanism that why many people come back and say, I'm better, not completely better, but I'm better. And it would also then make sense that when we add lifestyle factors to it, do we even get a better restoration of homeostasis of the pain biochemistry around the tissues that may help to explain why some people report improvement, and maybe a lack of change in the biochemistry explains why others might not. So that's one thing. I'm also interested in how do we support people to participate in exercise programs, and how do we mess with their brains in legal ways that they're not frightened to move. So I've got 3 PhD students at the moment who are looking at the role of virtual reality in the management of shoulder problems. And from my own clinical experience, of course, there's a bias when a person talks about their clinical experience, but I'm so excited about the potential of this technology in terms of improving the adherence of people to an exercise program, helping people graduate through an exercise program, but also in a legal way, messing with their brain to maybe reduce the fear of movement. And we've had some spectacular failures, but we've also had some really spectacular positive changes in people who've not moved their shoulder for 9 months, 2 years, that in a few minutes are moving normally and maintain that well after the treatment and the initial treatment. And so I tend to divide my rehabilitation into 3 phases. The first phase is restoration of movement. Second phase is improvement in muscle performance. And the third phase is restoration of function. And so for me, virtual reality is a very exciting technology on the horizon. It's here, but it's going to become a bigger part of what we do, I believe, in assessment and management. We just need more research on it. So those keep me excited. I've got some research on frozen shoulders, got some research on education, and a bit of research on lifestyle. So that will keep me occupied for the next 10 years.
Yeah, I think, well, good. I hope we can stick around for more than 10 years then, because we've got a lot of questions to answer. The mechanism is very interesting. I think that's coming back in terms of in play in regards to research as well. So that'll be interesting, especially when we don't know at this point. So I have this question is actually very relevant because you just were part of a publication that I think a lot of people are really interested in NJOSBT, and that was the advice paper that just came out, I think ahead of publication. And so the question I was going to ask you is, for those that are, either just entering physical therapy right now, or they're in PT school, or maybe they're newly graduated, they're kind of thinking about what they want to do, coming off that article there, what's some advice that you would give the new professional?
Read the article. It's all there. So it was a great team. Jared Powell, who's a PhD student in Australia, coming to the end of his PhD, led on it, and it was co-authors with Chad Cook and Karen McCreish, who was another PhD student who's now way surpassed me in her knowledge and her research skills, as Jared will any minute now as well. So it was a great team, and I think we had all slightly different ideas, but it came together in quite a hopefully useful way for new grads. And sort of, I think one of the big things that I've noticed that's changed is, originally in my career, you'd go to after work on Friday, you'd go to the pub in Australia, and you'd sit around all these manual therapy, physiotherapy experts and listen to their achievements of the week, and you'd sort of say, well, my gosh, I'd like to be like them, and I want to become the greatest fixer in the world, which I know a lot of people of my generation wanted to do. And so you apply for all these very difficult to get into postgraduate courses, and then you realize that maybe the reality doesn't live up to the expectation of those courses. And I think that's been replaced now. The Friday night pub, to a large extent, has been replaced by social media. And you get there's influencers in social media who are making ridiculous claims about what we should and shouldn't be doing, and to some extent bullying people, and to some extent, asking. And I think what we try to do in the paper is to try and balance that a little bit, and hopefully give people, like we try to give patients, confidence to manage. To clinically reason, to problem solve, to work things out for themselves. And I guess that was, for me, an important part of the paper. And, don't listen to people who are so adamant about the only way forwards is. And that was definitely part of the paper. But there's a lot more to it, and I would strongly recommend that everyone get a hold of it and have a read of it and comment on it. What was good, what could have been better.
Yeah, and the nice thing, we may even be able to link this in with this podcast, but it's open access at this point as well too, so it should be able to be readable for everybody. And I appreciate it, and obviously teaching in an entry-level PT program, it's important that we retain and keep people excited about this profession. I see a lot of things on social media where, like, man, it's like anything, like even with my kids, they're not like they can be influenced by so much, and a lot of it is not necessarily positive building or confidence building. And some of my research area is actually looking at burnout in physical therapy. And I do think that that's part of the consequence of some of these things that we see. And certainly that what you mentioned there, the confidence going forward, I think that definitely helps people with regards to, staying in this profession, being excited, hopefully, about it.
Yeah, I think that's, and I'm aware of what you're doing, and I think it's such a valuable contribution. And I wonder if, if we also changed our belief system from an I can fix you model to I can work with you model, to try and restore you to the highest level of function possible. And maybe we can stop burnout to some extent by not going to work thinking I'm failing because I'm not fixing people the way that people on social media are claiming we can, or people in the past in pubs have claimed that they can. And maybe if we go back more to the 1950s, which I think was one of the golden times of our profession, where if you think about your country in America, when there was the polio epidemic before Jonas Salk came up with the vaccine for polio, people in our profession were not trying to fix people with polio, but trying to work out how can we restore them to the highest level of function possible. And obviously that needs to be exercise, but like I said in the earlier part of this conversation, it has to be through lifestyle factors as well. And I wonder if we reduce burnout by actually changing our belief system and maybe making it more honest, with moving away from the I can fix you to I can work with you in a non-judgmental way, in a supportive way, and we can just take this as far as you want. Sort of like trying to help someone with depression or help someone with diabetes. That there's so much we can do. We can't fix these problems, but we can reduce the long-term disability. It's interesting, isn't it, that so many non-communicable disorders, diabetes, high blood pressure, depression, asthma, no one goes in and says, I want to be fixed. Of course we want to, but no one's got a Nobel Prize for medicine for that. But what we can do is we can put together a package of care that involves, educating why smoking is maybe not the great idea, why nutrition is important, why good sleep, hygiene, health is important, why a general exercise program is important. And by doing that, we can often reduce the disability. But when that patient's not fixed, but the disability is reduced, and we can also work out ways to try and maintain that for as long as possible and help people problem solve if there's a flare-up in blood sugars or there's a flare-up in the depression. But we're always there if they can't help manage the flare-up. And of course, all that can be supported by medicines as well. But And I just wonder if we took that approach with our musculoskeletal practice, if we would be offering, we're definitely offering more honest care, and maybe less burnout for people as well. And that's, to me, more important than a lot of the crazy debates that happen on social media at the moment that used to happen in the pubs, you know, back in the time when there was no social media in my life.
No, I appreciate it. So Jeremy, I want to respect your time. I want to respect our listeners' time, because I think people's attentions are around 30 minutes or so, and we're getting to about that point. And I'm going to leave a lot on the line because I want our listeners hopefully to come to Orlando, hear you speak, get a chance to meet you, and see me win a $10 bet. So,
all right, well, I'm going to get out a crispy $10 bill, and just in case I do lose, because I'll stick to, but we'll see. I'm pretty sure that it will be quite an empty hall the night after what is advertised as a pub crawl.
I don't know. All right, Jeremy. Well, thank you very much for your time, and have a great day.
Thank you, Derek. It was a great pleasure. Looking forward to catching up in person next month.
All right, we'll see you.